We're going to talk here about some basic principles of allergy. Allergy is something that you will commonly see in the clinic. So if you're working family practice or if you're a pediatrician, you're going to see allergy come up quite frequently, especially during certain times of the year, namely spring and early summer. Now, if you watch TV in the US where we advertise pharmaceutical drugs on TV a lot, you'll see that especially come early spring, you'll see Claritin and Allegra and these over-the-counter antihistamines come up a lot on commercials, and really there's a big industry behind it, and the reason is that allergy can really affect a person's quality of life, and so that just makes it all the more important that you're able to detect it. And a lot of people are pretty familiar with allergy, just lay people are familiar with allergy, but you should be aware of being able to differentiate allergy from something else like the common cold or flu or something that's not allergy, and that's primarily what I want to focus on with these videos here. We are going to talk about the pathogenesis of allergy. I don't want to spend too much time talking about it because it's primarily step one stuff. As far as knowing, the B cells and the antibody and stuff, it's good to have a superficial awareness of it, but I don't want to go too far in detail. I'll leave that for the individual disorders. We'll talk about some of the culprits. Again, this is good to know, but I just really want to touch on the basics here. We'll talk about the examination, some of the things that you might see, also how you're going to gather a history as a general approach to allergy. That's going to be really important in your diagnosis, and then some of the diagnostic tests that are done. So allergy as it is a type 1 hypersensitivity reaction. So in essence, what it is it's antibody mediated. Yes, there are T cells involved, but it's not a type 4 hypersensitivity in that it's not primarily cell-mediated, where you're getting cell-mediated destruction on behalf of macrophages. What we have here is the allergen being processed by an antigen-presenting cell, namely a dendritic cell. That allergen then being processed can be displayed, and as it's displayed, it can activate T helper cells. It can also activate memory cells, mast cells, eosinophils. As it does that, it induces type switching. That type switching allows the plasma cells to produce IgE antibodies, and IgE is the antibody, the immunoglobulin, that mediates allergy. Okay, so not IgG, not IgM, it's IgE. IgE is associated with allergy. And when you do quantitative immunoglobulins on a person who's allergic, it's going to be IgE that's going to be elevated. So our plasma cells make IgE. Our memory cells will sit here with antibody, surface antibody, and they will be able to then respond when you have another allergic encounter. Those antibodies will also be expressed on the surface of mast cells, and so when mast cells are, or when you come into contact with the allergen again, and that allergen then interacts with the antibody on the mast cell, those mast cells can degranulate, and they secrete all sorts of things. One of the more important things, though, that it releases is histamine, and histamine is a major mediator of the inflammatory response. So just comparing type 1 and type 4 hypersensitivity, type 1 hypersensitivity is the reaction we're concerned about in allergy. So you have a person who is in anaphylactic shock or is anaphylactic at all. That's a type 1 reaction. Or let's say, for instance, you have a runny nose because you are now exposed to oak trees. That's a type 1 reaction. A type 4 hypersensitivity reaction would be, for instance, if you brushed up against poison ivy. You don't get a rash right away. It takes 12, 24, 36 hours for that rash to develop. A type 4 hypersensitivity is a delayed hypersensitivity. It is, to some degree, an allergic reaction, but when we're talking about allergy, when we talk about allergy to peanuts, or allergy to house dust mites, or allergies in terms of asthma, we're talking about type 1 hypersensitivity, antibody-mediated hypersensitivity. So what happens here? Again, like I already said, when we look here, we have antigen presenting cell presenting the allergen ultimately to type, well, these are CD4 cells, type 2, so Th2 cells. These are helper T cells. These helper T cells will then stimulate B cells to produce IgE. The IgE then, I don't think this was, it's not on here, but anyhow, the IgE, there's receptors for that IgE which exist on various cells. Once you have enough IgE, they will then cross-link, and that sets off a cascade to allow these cells to degranulate. And what happens from this is you get vasodilation, congestion, smooth muscle contraction, and you can get anaphylaxis. And all of these effects are mediated by these chemicals that exist within mast cells and basophils and eosinophils. The time that this takes it varies, but it can be immediate, or it can take up to 4, 8, 12 hours, depending. There's various stages of type 1 hypersensitivity, of allergy, and we'll talk about those. So there's the early phase response. This is immediate. It's characterized by mast cell degranulation and the release of preformed mediators. That can be things like histamine, major basic protein. There are various interleukins that can be secreted. There is leukotrienes. There's prostaglandins, TNF-alpha, reactive oxygen species, lots of different things that can cause airway hypersensitivity, inflammation. So that's our early phase response. The late phase response is essentially chemotaxis. So what you have when you degranulate are various interleukins that allow neutrophils and eosinophils and basophils and lymphocytes to migrate to the localized spot of allergy. And when that happens, then you have all these other cells that are present, and it can perpetuate the allergic reaction. So essentially what we have with the late phase response is chemotaxis and a prolongation of the allergic reaction. So even though you don't have, so let me put it this way. You go up north, here in Minnesota we call it going up north. You go to a cabin, you go to a forested area, and there's birch trees everywhere. When I was younger, I used to go up to my aunt's house. She lived around a bunch of birch trees. You go up there, you get your immediate reaction. Okay, you got a runny nose, you got itchy eyes, and then let's say you leave. Even though you're gone, 6, 8 hours later, you're still having allergic symptoms. And the reason is because all you need to do is be exposed to enough allergen for a short period of time, and now you've set off a reaction, and now you've got all those chemotactic factors in your respiratory tract, in your skin, and in your eyes, and your nasal passages, and now you can develop this late phase response where you're migrating neutrophils and basophils and eosinophils to the site of allergy. And so you'll continue to have this late phase response. And so what you can have here is tissue edema, just a perpetuation of the allergic response that we saw in the early phase of allergy. Now, the chronic allergic disease sets itself apart from these other two in that the chronic allergic disease is something that you see when you are exposed constantly to the allergen over a long period of time. So with the chronic phase disease, what you have is over time, as you are exposed to the allergen, eventually these cytokines and these inflammatory mediators, what they can induce is tissue remodeling. So for instance, you have things like IL-4, IL-9, IL-13. They induce mucus secretion. They can also induce metaplasia of mucus cells. You have IL-4 and IL-13 can also stimulate fibroblast growth, and they can also cause fibrosis, synthesis of extracellular matrix proteins, which can change the geography of the tissue. Then things like TGF-beta, that can enhance subepithelial fibrosis, cause fibrosis of various tissues. Lichenification, which is something that we see with chronic, long-term atopic dermatitis. So with chronic exposure to these allergens, you can get changes in tissue structure. And this is really set apart from these more acute reactions of the early phase and late phase response, which is something that happens one time and it can happen again. But with the chronic allergic disease, this is more of a permanent or semi-permanent change. All right. Well, hopefully, from this, you get the idea of what happens when you're exposed to allergens. At least a basic idea. So what are the culprits? There are a lot, and this doesn't even begin to cover the surface of them, but these are some of the more common ones. There are allergens that you are exposed to primarily indoors, and there are allergens that you are exposed to primarily outdoors. Now, the ones that you are exposed to primarily outdoors, those are often known as the seasonal allergens. And the reason that they're referred to as seasonal allergens is because these allergens, different ones of them are going to be predominant in different times of the season. Now, a lot of this depends on where you're at. So if you're in a more temperate climate in the southern U.S., a lot of these are going to be present year-round. Now, if you are where I'm at, in quite far up north in the country, where it's a lot colder, we have seasons. We have a bona fide spring and summer and fall, and I imagine out in Europe it would probably be about the same thing, where you have more of a seasonal variation. Then these allergens are going to vary based on the time of the year. So tree pollen is going to be predominant in the late spring, early summer. This is just trees, their way of reproducing, I guess. I'm not a botanist. But what we see commonly are birch, alder, hazel, willow, and poplar. But there are tons of them. Then grass is going to be more common in the summer. That's things such as ryegrass is quite common, and then there's also something called timothy grass. Then weed is more common in the late summer and early fall. This is what I have a problem with personally, but that's things like ragweed, plantago, and nettle. So tree pollen is spring, grass is roughly summer, weed is late summer, early fall. There's a park not far from where I live, and I was taking my dog for a walk there, and I suddenly realized why I have such allergies since I've moved here. And there is ragweed absolutely everywhere. And this park, it's part of a nature preservation project to try to preserve the natural flora of the area. Well, they're exposing absolutely everybody in the area to these allergens. But these are our three major seasonal allergens. And the fungi and molds will be present primarily in the late spring to early fall. They go away when you have your first frost. So the cladosporium is the number one most common mold in the U.S. Other things that you'll see are Alternaria, Aspergillus, which we also see inside, Epicoccum, and Smuts, which is a class of fungi. What do we see indoors? This is going to depend on what you have around you and in your house, but house dust mites are practically in every house. You really can't avoid these little buggers, but they are going to thrive off of, as you can imagine, dust. What is dust? It's carbonaceous material, skin scales. And so these are going to be found in a lot of different places. They like to live inside bedding, pillows, carpet, upholstered furniture. Then cockroaches, this is something that you will see more commonly in inner city areas, older homes, homes where the walls and the floors aren't sealed very well, where there may be leaky pipes, where the cockroaches can get access to water. So that's something you'll see more in older homes. Older homes tend to be in inner cities. Animal products, so of course people are allergic to dogs and to cats. Cats probably more common. So this can come directly from their fur or dander. There's also, cats have a natural protein on them called FeLD1, and this is a common source of cat allergen. You can also be allergic to mice and then wool as well. And then there are some fungi that grow in homes. Penicillium is probably the unique one to indoor, but What's going to cause fungi to grow in a home? Certainly increased relative humidity. So relative humidity over usually 50% is when fungi start to be able to thrive. They're going to be more common in basements where there's more humidity. Certainly, if there's leaky pipes, that's going to make it easier for fungi to grow. So a lot of this you can gather. It's going to be really important to gather from the patient an idea of the kind of home they live in, uh, and from there you can make some inferences. However, with any of these, you're going to need to get an allergen skin test. You can't just make a diagnosis of what they're allergic to based on a history. You're going to need to get actual testing. And in a lot of cases, they're going to be allergic to several of these things. Other things you can be allergic to, more synthetic things, latex and metal. You can be allergic to various woods, certainly insect venom. So there's people that are allergic to bee venom who can become anaphylactic and die from that. And various drugs and foods. So what do we want to look at when we are gathering a history from a patient? A history is extremely important because it is from the history where we're going to be able to figure out whether this is allergy or not. So if this is something that just started happening 2 weeks ago and has never happened to a patient before in their life, and they're 13 years old, it's almost certainly not allergy. Allergy will begin to develop early on in childhood, not in infancy. We're talking more like 2 years old, in that ballpark. So this would be something that starts pretty early on. What you want to gather are the specific symptoms. So are they having runny nose, itchy eyes? Is there fever associated with this? Because certainly if there's a fever associated with these symptoms, it's probably not allergy. It's probably something more acute. You also want to know if there's any noted trigger. So like I said earlier, when I was younger and I would go up to my aunt's house up in sort of a foresty area, that would never trigger my symptoms. So if going to a certain person's house, maybe if they have cats there, that can trigger symptoms. Or if going to a park or going to a wooded area, if that triggers the symptoms, that's important to know because that can help you that can help you narrow down not only that this is allergy, but what type of allergens you should be looking for. And then when that trigger happens, what are the symptoms? How long does it last? And how often does this happen? Does it only happen when you go to that certain locale, or is it happening at other times too? You also want to know, is there exposure to common antigens? Now, this is going to be a little bit more difficult to ascertain directly out of the patient. However, you can get some of this based off of questions regarding where the child is or where the person is most of the time. So certainly when you're thinking about the environment the person lives in, what's one of the most important environments? Certainly your home. Why your home? Because you spend most of your time there. You sleep there. So you want to know the age and the type of the dwelling. So do they live in an apartment? Do they live in a home? If so, is it an older home? If you go into the inner city, some of those homes there can be 70, 80, 90 years old. You can have mold problems there. How is the house heated or cooled? So if you're not using air conditioning, the windows are probably going to be open in the summer and spring, and that's going to make it much easier for environmental allergens to come in. This doesn't really happen that much anymore, but if you're using wood-burning stoves or fireplaces or kerosene heaters, that can expose the person to irritants, and that can provoke symptoms that are similar to allergies. Also, are humidifiers used? Humidifiers they can raise the relative humidity over 50%, and that is how house dust mites and various fungi can thrive. If the relative humidity is below 50%, it's going to be very difficult for house dust mites to proliferate. Is there any history of flooding in the house? So when you have flooding, that that water can seep into the walls. And so even though you dry the house, if the walls of the house are still damp, which they will remain damp, then you can get fungi that grow, and then you can become allergic to that too. Is there carpeting? So a lot of homes are going to hardwood floors now, or linoleum. If you have a lot of carpet in the house, especially if it's older carpet, can harbor all sorts of things. It can harbor mold. It can harbor pet dander. It can harbor house dust mites. And so being exposed to carpet, particularly older carpet, but any carpet really, can worsen allergies. And so if a person is allergic chronically, we advise them, if possible, to replace the carpet, or better off, replace it with hard flooring. Is there pets? That's important, obviously, because people are often allergic to pets. So especially cats, but certainly dogs as well. And if there are pets in the house, where do they sleep? It's okay to have pets in the house, but and I'm certainly guilty of this. My dog sleeps on my bed. But that's generally not advisable. If a child has allergies, or really if anybody has allergies, it's preferred that that there are pet-free rooms in the house, wherever the child is most frequently, that the pet not be in that area, especially the bedroom. Other things to take into consideration is whether or not there are smokers. So if there's smokers inside the house, that can cause allergic-like symptoms, because the tobacco smoke being an irritant. You want to know where they smoke, so we prefer, if they must, that they do it outside. You also want to know other environments that the child may be exposed to, so perhaps this allergen exposure is not happening at home, but it's happening at daycare, or it's happening at school, or it's happening at a relative's house where the child may be exposed to allergens that they wouldn't otherwise be exposed to at home. So for instance, if they go to a daycare where there's cats, then they may be allergic to cats, even though there's no cats at home. Or if they go to daycare in a more rural area where there's birch trees or poplar trees or whatever, then they may be exposed to it there. Important to keep in mind, and I will bring this up again, but with cat allergens are very light, and they're very easily transferred, particularly that FeLD1. It's a very light, charged protein, and it can attach to all sorts of things, like clothes. As a matter of fact, they've done surveys in schools, where they've actually gone into schools looking for allergens, and they've found that there is significant cat allergens in schools, even though there are no cats, obviously, in schools. And the reason is because people just bring it in. So for some of these, they're so universal that you really can't avoid it. All right. Then, in addition to the environment, we also want to know the family history of allergies. So does anybody in the family, brother, parent, sibling, cousin, have asthma, or atopic dermatitis, or allergic rhinitis, or allergic conjunctivitis? Any of these things represent a family history of allergies. 50% chance child is going to be affected if one parent is affected with allergies, but a 2 in 3 chance if both parents are affected. So there's a significant family linkage here. And then you want to also know if there's been any response to previous treatment. Keep in mind that a lot of these drugs are available over the counter, the antihistamines. So if symptoms resolve or improve with Claritin, or with Tylenol PM, or with your first generation antihistamines, then that can point you towards allergy as well. What are some of the findings that we will see on examination? The most classic one is the allergic salute. And the allergic salute is something that you'll see in younger kids up to adults, but not in babies and not in very young children. But what this is rubbing the nose upward with the palm of the hand, and usually it's due to either a runny nose or an itchy nose. So we'll look at a picture of that in a little bit. If you do this enough, because you're pushing the nose up, you're sort of extending the nose, what can happen from this then is you develop this crease, this linear crease along the bridge of the nose. And this is just a deformity that comes from frequent allergic saluting. You can get allergic shiners. This is venous congestion in and along the eyes. So usually we're looking at the lower eyelids and sort of that area where you get bags around the eyes. This is a discoloration due to venous stasis. So it's going to be venous colored. It's going to be bluish to grayish to purplish in color, and it looks like almost like a black eye, like a minor black eye. And this is actually found in 60% of patients with allergic disease. Then there are these things called Dennie lines or Dennie-Morgan lines, and these are symmetrical skin folds that extend from the medial canthus along the lower lid margin and outwards. And I'll show you another picture of these two. These are pretty conspicuous if you see them. So here's the allergic salute. You've seen kids do this. You've probably done this yourself. If you have an itchy nose, this is a lot of times the way people will respond to it. And you can see here that there's this little crease that naturally forms when you do this. And if you do this enough, you'll actually get a deformity along that line. So here's some more pictures of kids doing it. Again, you see that crease here. And then here's the same child with that transverse nasal crease right here. So this is where the nose is being folded, and this is the same place where that horizontal nasal crease is forming. So here you can see it can manifest a little differently, depending on skin pigmentation, can look a little bit different, but it's just a line going across the nose, a horizontal line. There's not many things that can cause this. So make sure and check the nose when you're doing a workup on an allergic patient. Okay, so these are allergic shiners. They can be a little difficult to ascertain depending on how severe they are, but essentially what they look like are dark circles around the eyes. And this is just due to venous congestion. Now some people will think this is what happens when you get tired, and it can. However, it also happens in allergic reaction as well, and that's just due to the histamine causing vasodilation, which ultimately causes congestion, and that venous blood is then going to be congested in areas where you have rich vasculature, so particularly around the eyes. It's a little bit more conspicuous with this child here. That's a little bit more red, but the color is going to vary. You see it here too. Alright, and these are the Dennie lines. So these are just creases underneath the eyes, and they extend from the medial canthus outwards, roughly parallel to the lower lid. And you can see that this child has an allergic shiner too on this side. This is somebody who not only has the Dennie lines, but has what appears to be eczema, or some kind of atopic dermatitis, maybe. What do we do for diagnosis? So with diagnosis, you can go one of two ways. Most of the time, though, the initial test is going to be allergen skin testing. So we divide this into two different categories: in vitro testing, which is where we get a sample from the patient, we analyze it in the lab, versus in vivo testing, which primarily is the allergen skin test, where we actually inject the patient, their skin, with allergens, not much unlike the Manto test that you get for TB, which essentially is the same thing, and then we look for the response. So as far as in vitro testing, the most common hematologic abnormalities that you can see with allergy is going to be eosinophilia, more than 450 eosinophils per microliter. The presence of eosinophils, or the presence of a hypereosinophilia, is very sensitive for allergy, but it is not at all specific, and so typically we can't use that. Now, on the other hand, if you were to get a nasal secretion analysis in a patient who already has symptoms of symptoms of allergy, well, asthma too, but symptoms of allergy, and you were to find that there are excess eosinophils in the nasal secretion, that is relatively specific for things like allergic rhinitis. What are the other things we can do? So RAST testing. What is RAST? RAST is a test that it's very similar to the ELISA test, except it uses more immunofluorescence. But essentially what you're doing is looking for allergen-specific immunoglobulins, which would indicate that this patient has allergy to that specific allergen. And it's just a biochemical test. You don't need to know how it's performed. All you need to know is that RAST, which has primarily has been, for the most part, replaced by ELISA. These tests look for allergen-specific immunoglobulins. So you can do testing for nickel allergen. You can do testing for house dust mites. You can do testing for anti-mouse antibody. There are all sorts of different tests you can do. Oak, poplar, it really, you name it. So these are in vitro testing, and these are not done very readily. Most of the time we go to allergen skin testing because it's easier to do. It's less expensive, but this can be done if the patient can't tolerate allergen skin testing, and I'll talk about why a patient might not be able to tolerate that. Okay, so the in vivo testing mostly is the allergen skin testing. Allergen skin testing is usually the first test performed, and there are two different ways that you can perform this. You can perform this with a prick puncture technique where you're just doing, I'm not sure what, I think it's just subcutaneous, where they're just going in below the very first layer of skin. This is very similar to the Manto test. It's pretty much the same thing. And they're introducing allergen, and then I think like 2 days later they look to see how much induration there is. And if there is, then it means there's an allergic reaction. There's another way you can do this. You can go deeper, and that's called an intradermal technique. It's more sensitive, but we try to avoid it because there's a higher risk of severe reaction. And there are various, again, pretty much anything you can think of under the sun. We'll look at some pictures where you can see that there's a lot. They can do 40, 50, 60 allergens at a time, and they just mark these, and then they can see if there's reaction, and then if the patient is allergic to those various things. Other tests that can be done in vivo are provocation testing. So we see this when we're looking for asthma, the methylcholine challenge test. We try to avoid this because, again, there's a risk of developing an anaphylactic reaction. So this is allergen skin testing. So what they're doing here is they're taking allergen and just injecting it slightly beneath the skin here, and then we see there's positive reactions in some of these, and then other ones there's not. So they measure them. You don't need to know exactly how to do this, just know this is a common way of testing for allergy. So here you can see that there were like 50 things being tested all at the same time. You see some of these, there's severe reactions, other not so much. So this patient is clearly allergic to birch, other various trees and grasses, and then very clearly allergic to dust mite, and then not so much mold. So and then they usually do this control, where with the control they'll inject like saline or something, and then for the positive control they'll inject histamine. So you can see what would be a normal reaction, which would be our negative control, and then what would be our allergic reaction, which would be our histamine or positive control. All right, so I think for the most part that's all I wanted to get to with this. So again, you can see here. Here it looks like they're testing for food allergens. So you can see rye, tomato, rice. So this person has a rice allergen. That's interesting. All right.